So good evening, doctors. So shall we start, Chitra?
Yes, Sam.
Good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is recurrent pregnancy loss. I welcome all the participants and I request them to post their queries in the comment box so that we can have a short Q&A session at the end of the presentation. Before going to session, I request the speakers to play a 1 minute video on Shield. Participants can make use of it. Chitra, you can play the video on show. So the Shield Healthcare is a new initiative of our Shield Healthcare, and you can see the various updated. You can see various blogs written by our experts. It is available in our Shield Connect webpage. So you can see the various blogs written by various experts in our website, and you can see the details of our webinars. So all our webinars are conducted through our Shield Connect webpage only. So you can see the informations of upcoming webinars and the past webinars which we have conducted in the past 8 to 10 months. So all informations are available in our website, and we also have a separate page for PCOS awareness. So we have short videos of various experts explaining about PCOS in their own regional languages. So you can see a number of videos in our web page, and we also have another page for our leaders. So you can see informations of our leaders who are supporting us, our web page through their webinars and their scientific contents which are posted in our websites. And I request the participants to post their that is go through our website and make use of this Shield Connect webpage. Thank you. Now it's time to introduce our speaker for the day. We have two topics today. The first one is trends in management of recurrent pregnancy loss. We have our invited speaker, Dr. Aruna Kumari ma'am. So, madam was graduated from Rangaraya Medical College, Kakinada, and has done her post graduation from PG Institute of Medical Education Research, Chandigarh. And madam was also worked as a senior resident in PGIMER, and madam was awarded received various awards like Srinivasa Rao Memorial Award in Surgery and Srimati Susila Bai Sadasiva Rao Prize in Ophthalmology. And Madam is currently having experience in doing operative laparoscopy and operative hysteroscopy apart from general gynae and obstetrics. Madam is currently associated with Arsha Hospitals. Madam has started a IVF center for infertile couples. With this introduction, I welcome you, ma'am, and I request you to take over the session, ma'am.
Thank you, sir. Thank you so much. So today my topic for this webinar is recent trends in management of recurrent pregnancy loss. First, let me thank Shield people to starting such an innovative platform that is Shield Connect to educate all of us and allowing me to participate in this platform and to share few of my views in recent trends in the management of recurrent pregnancy loss. Thank you. And today I'm very happy to share this dais with my best friend and my real loving senior, Dr. Suma Prasad, in sharing my views. So, coming to topic, recent trends in management of recurrent pregnancy loss. As we all know, this pregnancy loss is a significant negative lifetime event in patient's life. When it recurs, we know how distressing it is. And also it's very frustrating for us also because after a thorough intense workup also,
Sorry
only
for interrupting.
50% of it, is it audible?
Yes,
Shall I
you are
continue?
audible,
Sorry, ma'am. Ma'am, you are audible. You have to share your screen, ma'am.
Okay, sorry. Is it okay?
Yes, ma'am.
Yes, ma'am. Yes,
Are my slides visible?
Yes, perfectly fine, ma'am.
Fine. Shall I start now?
Yes, ma'am.
So, directly going into the topic. So, what is recurrent pregnancy loss? By definition, it is 2 or more pregnancy losses from the time of conception to 24 weeks or before fetal viability. Previously, we used to say the recurrent pregnancy loss means 3 or more consecutive losses. But according to recent guidelines by ISHRA and ASRM, it is 2 or more pregnancy losses are known as recurrent pregnancy loss. Why? Because after 2 losses or 3 losses, the etiology remains the same. And by starting evaluating these patients early, that is after 2 losses, we can prevent some of the preventable losses. And in this definition, the biochemical pregnancies, the molar pregnancies, and the ectopic pregnancies are not viable, not included. Only those clinical pregnancies are included. And what is primary recurrent pregnancy loss? That is, there is no previous viable pregnancy. If there is a previous viable pregnancy, then it is known as secondary recurrent pregnancy loss. This recurrent pregnancy loss can be consecutive or non-consecutive. Whether it is consecutive or non-consecutive, the underlying etiology and the management guidelines will be the same. Coming to the incidence of the recurrent pregnancy loss, it is around 1 to 5%, depending upon the various definitions included. The risk of miscarriage in the first pregnancy is around 10 to 13%. As we all know, our human reproduction is very inefficient process. The human fecundity rate is only 30%. That means only 30% of conceptus embryos formed will reach viability. Remaining 70% will lose before they reach viability. Out of them, 30% we lost. 30% of embryos will lost from the time of fertilization before implantation itself, and 30 more will lose by the time of missed period, and remaining 10% will present as these spontaneous abortions, which we are going to discuss today. With each increasing number of miscarriages, the chances of miscarriage will increase. Coming to various causes of recurrent pregnancy loss, there are so many etiologies put forward, but today I'm going to discuss the main and common etiological factors. They are genetic factors, which account for around 2 to 5%, and these are the commonest causes for early first trimester pregnancy losses. The second one is the anatomical factors, which accounts around 10 to 15% of pregnancy losses, which causes second trimester pregnancy loss. The other is autoimmune causes, which can account for around 20% of recurrent pregnancy loss. This topic will be discussed in detail by my senior Dr. Suma Prasad Madam. The other causes are endocrine factors, which can account for around 17 to 20%. And the other causes which may account for minority of recurrent pregnancy losses are inherited thrombophilias, chronic maternal illnesses like renal failure, renal problems, or chronic hypertension, or SLE, or any other connective tissue disorders can cause recurrent pregnancy loss. Infectious factors as a cause of recurrent pregnancy loss is very rare. Usually they can cause single sporadic abortion. There's some role of male factor in causing these recurrent abortions. Like increased DNA fragmentation index or increasing age, or those male patients with chromosomal abnormalities can cause recurrent pregnancy losses. The other factors like decreased ovarian reserve and environmental factors can also contribute to some amount of pregnancy loss. In spite of thorough workup of all these factors, around 40 to 50% of cases, the cause of infertile recurrent pregnancy loss is unexplained. So now I'm going to discuss a little bit around these common factors, that is genetic factors, anatomical factors, endocrine factors, and finally I'll summarize how to manage these patients. Coming to genetic factors. This is the most common cause of first trimester miscarriage. Around 90% of recurrent pregnancy losses due to genetic etiology will occur before 6 weeks of pregnancy. That is very early first trimester miscarriage. These genetic abnormalities can be a chromosomal disorder or single gene disorder. But for recurrent pregnancy loss, the commonest genetic abnormality is chromosomal disorders. When the genetic etiology can be suspected in cases of advanced maternal age, if there is repetitive first trimester losses, or if there is a history of anembryonic pregnancies, or if there is history of malformations or mental retardation during previous pregnancies, or if there is a family history of congenital abnormalities in the siblings, or if the history of offspring having unbalanced chromosomes, or if previous pregnancy products of conception chromosomal analysis showed any translocation, then we should suspect some genetic etiology in those commissioning couple. The genetic factors will be less likely with the late first trimester or second trimester losses. Coming to evaluation. So the genetic factors should be evaluated both in the parents and in the products of conception also. So whenever we suspect the genetic etiology, as we already discussed, the factors like repetitive first trimester abortions, or if there is a history of malformed or congenitally abnormal child, then these parents should be subjected to genetic and chromosomal analysis. And in 2 to 5% of these couple will have balanced reciprocal or Robertsonian translocations, or mosaicisms, or inversions. The balanced translocation means in these patients, the chromosomal material will be lost from the chromosome, but it is not totally lost. It is translocated into other chromosome. That is balanced translocation. The parent will be phenotypically normal. But when this material is transmitted to the conceptors, the conceptors may develop unbalanced translocation, which may be not compatible with the life, or a unbalanced translocation where the baby may develop some malformations or mental retardation, or the baby may have balanced translocation as a father and phenotypically normal, or the baby may have normal chromosomal set with phenotypically normal. Anything can happen. But mind you, with this balanced Robertsonian translocations, these parents will have a chance of having more than 60% to have a normal live-born child. Although there is a risk of miscarriages and malformed children are more in these parents, the chance of cumulative live birth rate is around 60%. Coming to genetic analysis of baby, that is analysis of products of conception, abortus material, with the advent of advanced technique in genetic analysis like 24 chromosomal microarray, next generation sequencing. Now we are getting more information from the abortus material. Previously, we used to do conventional karyotyping and the products of conception. Then we used to get very limited reporting. For many patients, we used to get no report because of culture failure or because of maternal contamination. Only less than 30% we used to get the report. But with the advent of these advanced techniques, now more than 90% of cases we are getting report for the analysis of the genetic analysis of these products of conception. And among them, 60% of material are showing abnormal results, abnormal chromosomal material, which may explain the cause for this pregnancy loss. That means with the addition of this genetic analysis of products of conception with the advanced techniques, in more than 90% of cases of recurrent pregnancy loss, we are getting the answer. What is the cause for this loss? The analysis of these products of conception can give us three types of results. One may be unbalanced translocation or inversion. The unbalanced translocation, which is not compatible with life, means this concept is got this unbalanced translocation from the parents. The parents got balanced translocation, which got unbalanced. That means this is the cause for recurrent pregnancy loss. This couple can have repeated abortions because of this genetic etiology. The other group can have aneuploidy. Aneuploidy can occur in around 55% of analysis of these products of conception. And this aneuploidy is the cause for that abortion, that sporadic abortion. It won't cause a recurrent pregnancy loss. This is a sporadic event and maybe the cause for pregnancy loss during that pregnancy, which doesn't recur during next pregnancies. So we can leave that case. The third variety can be, we can have a euploid result for the chromosomal analysis of these products of conception. That means the cause for this index pregnancy loss is not abnormal conceptus. The cause is maternal cause. Then a full recurrent pregnancy loss workup is recommended in this mother. So by analyzing these products of conception, we can come to a conclusion whether the cause of this recurrent pregnancy loss is a genetic, that is an unbalanced translocation, or maternal cause, or it's a sporadic event. Coming to treatment of genetic etiology, and all patients who have this genetic etiology should undergo genetic counseling. During genetic counseling, first these patients should be counseled and reassured regarding the probability of having a chromosomally normal baby. The chance is more than 60%. And they should also counsel regarding the chance of their high risk of having risk of miscarriages, or they have a chance of bearing a chromosomally abnormal baby who may be phenotypically normal or abnormal, or they may have a chance of having a carrier of this chromosomal defect. And they should be counseled regarding the availability of various treatment options. These treatment options can be a prenatal genetic studies like either chorion villus sampling or amniocentesis. When this couple with abnormal chromosomal analysis conceives, then we should do either amniocentesis or CVS to diagnose for the presence of any unbalanced translocations in the conceptus, and depending upon the result, we can counsel the patient regarding either termination or continuation of the pregnancy. The other modalities available for the treatment of this genetic etiology is in vitro fertilization with pre-implantation genetic diagnosis. That means we will form an embryo with IVF, and then we'll do biopsy of the blastomere, and we'll subject these cells to either CMA, that is 24 chromosomal microarray, or next generation sequencing to see any chromosomal abnormality in that embryo. And we'll exclude all those embryos which is having abnormal configuration, either monosomic diseases or aneuploidies or unbalanced translocations, and we'll transfer only those healthy embryos. With this technique, we can decrease the miscarriage rate and we can improve the live birth rate. The other options available for these patients where there is severe abnormality, like reciprocal translocation, where 21 translocation, where the chances for recurrent Down syndrome is very high, or some abnormal chromosomal configurations where the chance of having live born viable child is very rare, then we can give them an option of gamete donation. Depending upon which parent is affected, either egg or sperm can be donated or adoption can be advocated. Coming to anatomical factors. This is the most common cause in second trimester pregnancy loss, and these anatomical factors are responsible for 10 to 15% cases of recurrent pregnancy loss. These can be either congenital uterine malformations or acquired intrauterine abnormalities. The most common congenital uterine malformations that can cause recurrent pregnancy loss are septate uterus, unicornate uterus, bicornate uterus, didelphic uterus, or abnormal T-shaped uterus. The common acquired intrauterine abnormalities that are associated with recurrent pregnancy loss are endometrial polyps, fibroids, intrauterine adhesions, cervical insufficiency, and adenomyosis, etc. So coming to evaluation of anatomical factors, there are so many tests are available, like hysterosalpingogram, which is very poor in evaluating intracavitary lesions, transvaginal ultrasound. This is the most widely available and non-invasive technique. And for those patients where there is suspicion of anatomical factor, all those patients who are having recurrent pregnancy loss should be subjected to transvaginal ultrasound examination to rule out any intracavitary lesions. If we have any suspicion of intracavitary lesion or submucous fibroid or polyp, it can be supported by using sonohysterosalpingogram. In this technique, we instill normal saline into the cavity, and intracavitary lesions will be well delineated. And the diagnosis of polyp and submucous fibroid can be done with confidence. And coming to uterine malformations, we can differentiate septate uterus from bicornate uterus with use of the sonohysterography. The three-dimensional ultrasound, wherever it is available, is very accurate in diagnosing uterine anomalies. According to recent guidelines by ISHRA, they advocate to do 3D ultrasound in all patients having recurrent pregnancy loss to rule out uterine cavity abnormalities. So coming to magnetic MRI, its routine use is limited because of its high cost, but it has a real valuable role where there is a suspicion of diagnosis or any doubt of diagnosis of these uterine abnormalities. Coming to hysteroscopy and laparoscopy, these are the gold standards in diagnosing these uterine anomalies, but their role is restricted to only corrective surgeries. That means for diagnosis of this uterine anomalies, we should not do these hysteroscopy and laparoscopy because they are invasive procedures, and less invasive procedures like 3D ultrasound and MRI are available for the diagnosis. So the role of hysteroscopy and laparoscopy is only for corrective surgeries. Coming to management of these abnormalities, coming to septate uterus, is the most common developmental anomaly associated with recurrent pregnancy loss. If it is not corrected, the miscarriage rate is around up to 65%. The mechanism how it causes recurrent miscarriage is not well understood, but there's so many theories are put forward. Maybe it can be an implantation of the baby in a poorly vascular septum, or maybe because of poor decellularization of the endometrium, or maybe increased contractility of the uterine cavity because of the muscular septum, or maybe because of narrowing of the cavity because of presence of septum. Whatever may be the underlying cause, these septate uterus are associated with more than 65% cases of miscarriage. So the treatment is hysteroscopic septum resection, which is really very, very easy surgery in efficient hands. And after hysteroscopic septal resection, the near normal pregnancy outcome is very good. The term delivery rate is around 75% and viable live birth rate is around 85%. Coming to unicornate uterus. No surgical procedure can enlarge unicornate uterus. The best thing in this uterine congenital anomalies is with each pregnancy, the period of gestation will increase. That means if this patient has an abortion around 20 weeks period of gestation, the next time when she conceives, the pregnancy will prolong because of there will be increasing in uterine capacity and volume with each pregnancy, and the period of gestation will increase. If she has abortion around 20 weeks during previous pregnancy, this pregnancy she may continue her pregnancy up to 24 to 28 weeks. So conservative management will help in these uterine malformations. Available evidence suggests that most pregnancies are best managed expectantly because of this increasing capacity of the uterus with each increasing pregnancies. And cervical circulars is reserved for those patients with trimestral miscarriage, or if there is evidence of progressive cervical shortening on serial ultrasound surveillance in this unicornate uterus. Coming to bicornate uterus, again, the best management is conservatory. As we already discussed, with each pregnancy, the period of gestation will increase, and the surgical procedure which is available for the bicornate uterus is Strassman's abdominal metroplasty. Is associated with many complications, and the pregnancy rate is very less after this procedure. So this surgery is best reserved for those with a well-established history of recurrent pregnancy losses or pre-viable births. So the main management option is conservative management. Coming to uterus diadelphys, again the same management, conservative management. The only surgery indicated in uterus diadelphys is removal of obstructing longitudinal vaginal septum, which may interfere with the intercourse and conception. And unification procedure can benefit only some women with numerous miscarriages or pre-viable deliveries. If we plan unification, the unification procedure recommended technique is that unifies the two fundi, but they left these two cervix apart. If you try to unify those cervixes, it may lead to cervical incompetence. So coming to cervical insufficiency, this is the most commonest cause of mid-trimester recurrent pregnancy loss. The cervical insufficiency is defined as recurrent second trimester pregnancy losses that were associated with painless dilatation of the cervix and birth of a live fetus, often between 16 to 28 weeks of gestation. Again, in cervical insufficiency, the history is the success of pregnancies may be associated with progressively earlier delivery. Opposite to congenital malformation, what happens here, if this patient has a pregnancy loss around 22 weeks in this pregnancy, the next pregnancy, the pregnancy loss occur at an earlier gestation, maybe around 18 to 20 weeks. Why? Because with each successive pregnancies, the cervical incompetence will increase. Coming to diagnosis of cervical insufficiency, the main diagnostic feature is pathognomonic history. The history is the painless dilatation of the cervix. Usually, the patient presents to the OPD with complaining of little pelvic pressure, little back pain, and little discharge. If you do the per vaginal examination, the cervix will be fully dilated with bulging bag of membranes. And this event will be repeated successively in each pregnancy if we want to corrective surgeries in this patient. So there's so many tests are advocated in between pregnancies to diagnose cervical insufficiency, like passage of Hagar dilator without any resistance, or fully catheter bulb fraction test and HSG, but none of them are useful. The only gold standard for diagnosis of cervical insufficiency is transvaginal sonogram surveillance during pregnancy. So in all suspicious high-risk cases, that means all those patients who have typical history pathognomonic of cervical insufficiency, or all those patients who have history of cervical trauma or that is repeated dilatations, or those patients who have cervical surgeries like LEEP surgery or trachelectomy, and all those patients who have history of congenital malformed uterus like bicornate uterus, septate uterus, unicornate uterus. Sometimes these congenital malformations may be associated with cervical insufficiency. So in all those patients who are high risk for cervical insufficiency should undergo serial sonography monitoring, transvaginal sonography monitoring starting from 16 weeks, should continue up to 24 weeks period of gestation. During this transvaginal sonography, we will evaluate the length. We will look for the cervical length. If the cervical length is less than 30 millimeters, then this patient should undergo repeat sonogram after 15 days. If this length of cervix is less between 25 to 29 millimeters, then we should repeat the sonogram after 1 week. If this length is less than 25 millimeters, then we should apply surclass in this high-risk group of patients. While during this serial sonography surveillance, if this cervix is gradually shortening, that is in first sonogram it is around 33 millimeters, in second sonogram it is around 30 millimeters, in third it is 29 millimeters, then we should apply the surclass. There's no need for us to wait till the cervix becomes 25. If there is a gradual shortening of the cervix, or the cervical length is at 25 mm or less, then this patient should be subjected for cervical surclass application. The other features which may give us a clue that this patient is having cervical incompetency are presence of cervical funneling, or diameter of the internal os more than 15 mm in first trimester, or more than 20 mm in second trimester, or prolapsing membranes from the cervix, or presence of fetal membranes or fetal parts in the cervical canal. All these features will give us a clue that this patient is having cervical incompetence. Then what is the management? Management is only surgery, surgical management. That can be either transvaginal surclass or transabdominal surclass. The transvaginal surclass is the most commonly used surclass procedure. It can be either McDonald, Shirodkar, or worm surclass, which we'll discuss in detail. Transabdominal surclass is very rarely applied. It is indicated in cases where there is failure of transvaginal surclass in previous pregnancy, or there is very short cervix, or there is a lacerated cervix, or there is surgeries on the cervix like trachelectomy or excision of the cervix or LEEP surgery. These patients should undergo abdominal surclass procedure. This abdominal surclass procedure can be done either before pregnancy or during pregnancy around 12 weeks period of gestation. During this procedure, what will you do? We will do laparoscopy and we'll separate the utrovesical fold of peritoneum and we'll push the peritoneum down and we will apply Mercelin tape around internal os and we'll tie the knot and we'll again approximate the utrovesical fold of peritoneum. Coming to surclass procedure, the main principle is a non-absorbable encircling suture is placed around the cervix at the level of internal os. In McDonald surclass, we use non-absorbable suture and take a purse string sutures around the as high as possible on the cervix. In Shirodkar surclass, we separate the retrovesical fold of peritoneum and we'll push the bladder up, and posteriorly we separate the rectovesical fold, rectovaginal fold of peritoneum and push the peritoneum up, and we'll apply the stitch, and again we'll close the peritoneal folds. What is the timing? When should we apply the circulars? In elective circulars, in proven case of cervical incompetency with the pathognomonic history in the previous pregnancies, the circular should be applied around 14 weeks of period of gestation, or at least 2 weeks earlier than the lowest period of previous wastage, pregnancy wastage. And it should be applied only after 10 weeks period of gestation. That is, once the baby crosses the period of 10 weeks, then only we should apply the circulars. Coming to emergency circulars, when the cervix is already dilated and the membranes are prolapsing, then to save that pregnancy, we will apply emergency circulars. In this, what we will do, we will push the membranes inside and we apply a bursting suture on the cervix as high as possible. In cases where the cervical dilatation is more than 4 centimeters, or the membranes are prolapsing beyond the cervix, or there is evidence of infection, or if the patient is in labor, or if there is bleeding, or if there is rupture of membranes, we should not attempt circulars, as this is associated with high failure rate. What are the contraindications for circulars? That is, as we discussed, evidence of intrauterine infections, ruptured membranes, history of vaginal bleeding, severe uterine irritability, or patient in labor, a cervical dilatation more than 4 centimeters, we should not do circulars. Okay, we applied the circulars and the pregnancy continued and the baby reached viability and went to remove. The circular should be removed around the 36 to 37 weeks period of gestation, where the baby will reach viability. Or whenever there is a complication, like if this patient goes into labor, or if there's rupture of membranes, or if there's evidence of infection, then we should remove the circulars and should conduct the delivery. Coming to other acquired malformation, other acquired abnormalities, that is uterine leiomyoma. It is very unclear the relationship between the uterine leiomyoma and recurrent pregnancy loss. The pregnancy outcomes are adversely affected by submucous leiomyomas and intramural myomas that are more than 5 to 7 centimeters in size. The large submucosal fibroids that distort the cavity or occupy large subendometrial area should be removed because they are associated with pregnancy loss. Surgery is not indicated when or it is an intramural myoma less than 4 centimeters, or if it is subserous myoma. The treatment options, whenever it is causing distortion of the cavity, then we should remove it either hysteroscopically or through abdominal biomectomy, either laparoscopically or through laparotomy. Coming to intrauterine adhesions, that is Asherman syndrome. The main etiology for Asherman syndrome is excessive curettage for pregnancy complications. What will happen? It will traumatize the basalis layer, leading to granulation tissue. And there's insufficient endometrium to support the fetoplacental growth, leading to recurrent miscarriages. Usually these patients will present with menstrual irregularities, either hypomenorrhea or amenorrhea or cyclical pelvic pain and infertility. The diagnosis is primarily with high index of suspicion. This typical history, that is hypomenorrhea or amenorrhea, and usually the diagnosis will be confirmed by estrogen progesterone withdrawal bleeding. There will be scanty or no withdrawal bleeding after sequential treatment with estrogen and progesterone. The treatment is operative hysteroscopy and additionalysis. After additionalysis, the recurrence rate is very high, around 20 to 40%. So many advocate to insert intrauterine balloon catheter, that is Foley's catheter number 16, the bulb inflated up, Foley's catheter number 8, the bulb inflated up to 3 mm of cell line. And this catheter should be left in situ for at least 1 week. And the treatment with broad spectrum antibiotic and non-steroidal anti-inflammatory drugs is advocated to prevent uterine contractions uterine cramping because of these balloon catheter and to prevent infection. And high dose exogenous estrogens are educated at least for 4 weeks to enhance epithelialization of the endometrium and to improve the success rate. So to summarize anatomical factors, it can be congenital uterine malformations like septate uterus, which is most common congenital uterine malformation that causes recurrent pregnancy loss. And luckily, the hysteroscopic metroplasty is very efficient surgery in improving the outcomes. Unicornate uterus, the uterine reconstruction is not feasible, but conservative management can improve the results. Bicornate uterus, this transverse metroplasty is associated with many complications. So again, the conservative management is advocated unless there is the history of many previous losses. And didelphic uterus also, the conservative management is the treatment of choice unless again there is many losses where the unification procedures can be attempted. Coming to acquired intrauterine abnormalities, endometrial polyps, any polyp more than 1 centimeter should be removed hysteroscopically to improve pregnancy outcome. And fibroids, those fibroids which are causing cavity distortion should be removed either hysteroscopically or laparoscopically. And intramural fibroids more than 4 centimeters, if this patient is having infertility, should be removed. And intrauterine adhesions, hysteroscopic removal of intrauterine adhesions is advocated. Coming to cervical insufficiency, if it is proved, circular should be applied. On those patients with irreparable anatomic uterine abnormalities, the choice of IVF with transfer of embryos to an appropriately selected gestational carrier, that is surrogacy, can be advised, or adoption. Coming to immunological diseases, this can be discussed in detail by my friend Dr. Suma garu, so I'm not going to touch this. Coming to endocrine factors. So endocrine factors that predisposes to an increased risk of pregnancy loss, which accounts for around 8 to 12% cases of recurrent pregnancy loss, are thyroid disease, diabetes mellitus, polycystic ovarian syndrome, luteal phase deficiency, etc. Coming to thyroid diseases, hyperthyroidism or Graves' disease is usually associated with obstetric complications or sporadic abortion, but it is not associated with recurrent pregnancy loss. Coming to hypothyroidism, this overt hypothyroidism or subclinical hypothyroidism are associated with isolated miscarriage as well as recurrent pregnancy loss. Patients with hypothyroidism, even subclinical, have an increased rate of spontaneous and recurrent miscarriages because they have concomitant abnormalities, include ovulatory dysfunction and luteal phase defects. So at present, the current recommendations is to supplement levothyroxine to all those patients who are trying for pregnancy when the thyroid TSH level is more than 4 milliunits. So we should start treating these patients with subclinical hypothyroidism. Coming to association between antithyroid antibodies and recurrent pregnancy loss. The association is unclear, but many studies showed that those patients with thyroid autoimmunity have increased chances of miscarriage and recurrent pregnancy loss. So the current guideline says all those patients who have TSH levels more than 2.5 should undergo tests for thyroid autoimmunity. If these patients are positive for TPO antibodies, then we should start supplementing levothyroxine for these patients when the thyroid level is TSH level is more than 2.5 to improve pregnancy outcome. Coming to diabetes mellitus. Poorly controlled diabetes mellitus, where the increased blood glucose levels and HbA1c levels are increased in first trimester, the risk for recurrent pregnancy loss is very high. So what are the ideal levels we should achieve before planning pregnancy? Before meal, the capillary blood glucose concentration should be between 80 to 110 milligrams per dl. And 2 hour postprandial glucose concentration should be less than 155 milligrams per dl. So before planning pregnancy, the diabetes should be strictly controlled. The sugar level should be, these levels should be achieved. And coming to HbA1c, the preconception HbA1c goal for all women with diabetes is less than 6.5. If this diabetes is well controlled, the risk of recurrent pregnancy loss will decrease. One more recent advance in the management of this gestational diabetes is the metformin and glyburide are effective and safe in management of gestational diabetes. That is, we can use these oral drugs during pregnancy. But long-term outcomes of the infants of pregnancy treated with these oral agents are very sparse. So at present, the insulin remains the first choice, but there are many studies which are showing the safety of these oral drugs also during pregnancy. Coming to polycystic ovarian syndrome, characterized by excessive production of androgens by ovaries. The increased risk of miscarriage in PCOS is due to increased insulin resistance, hyperinsulinemia, and hyperandrogenemia. So, there are many papers and theories which show that metformin can reduce the risk of miscarriage in PCOS by decreasing its high insulin resistance. But recent meta-analysis of 17 randomized controlled trials showed that metformin has no effect on decreasing miscarriages. Again, uncontrolled small studies, they are not randomized controlled studies, but there are many papers which are shown that metformin is associated with decreased risk of recurrent miscarriage. And there's already many papers which showed metformin is safe during pregnancy. So in case of recurrent pregnancy loss associated with PCOD and increased insulin resistance, we can try metformin. Coming to luteal phase deficiency and recurrent miscarriage. Luteal phase defect is a condition in which inadequate production of progesterone by the corpus luteum takes place and consequently results in inadequate development of endometrium. Several studies reported lower than normal serum progesterone concentration in patients with unexplained recurrent miscarriages. That means luteal phase deficiency is there in some group of patients with recurrent miscarriage. Findings from a study supported that the existence of condition of luteal phase defect as an entity and has a clinical significance in recurrent first trimester pregnancy loss. So coming to role of progesterone in recurrent abortions, there is insufficient evidence to evaluate the effect of progesterone supplementation in pregnancy to prevent miscarriage. So as we all know, there are so many papers and scientific evidence to prove that progesterone is responsible for immune cascade of pregnancy and is known as immunomodulator of the pregnancy. The progesterone will help in maintaining early pregnancy in many ways. It will improve the secretory changes of the endometrium and it will cause decidualization of the endometrium, which will improve implantation process, and the progesterone has an effect on cellular immunity and humoral immunity. It will cause shift from Th1 immunity to Th2 cascade, and it will also act as a tocolytic. It will also decrease the uterine contractions during the time of implantation, and there's so many other actions put forward as progesterone is the key factor in early pregnancy maintenance. Therefore, in the absence of any factor, progesterone is given till the placenta takes over the luteal function to prevent recurrent miscarriages. The type of progesterones can be either natural micronized or synthetic, that is dihydrogesterone. There are many trials in the literature which showed the efficiency or inefficiency of the progesterone in recurrent pregnancy loss. Among them, the PROMISE trial, where the 400 milligrams of vaginal micronized progesterone twice daily or placebo is used in these patients from the time of positive pregnancy test to 12 weeks of gestation. while analyzing the results, there is no difference between the two groups, either progesterone group or placebo group, in miscarriage rate or live birth rate. That means, according to this trial, the progesterone is ineffective in preventing recurrent pregnancy loss. At the same time, there is an Egyptian trial where they commenced the treatment, progesterone treatment, in the luteal phase immediately after documentation of ovulation, and this progesterone supplementation is continued till 28 weeks. They found the significantly lower miscarriage rate and higher live birth rate. That means, if this progesterone to be useful to prevent miscarriage or recurrent pregnancy loss, this progesterone should be started in luteal phase. A meta-analysis of 10 RCTs involving 1,586 patients with idiopathic recurrent pregnancy loss showed that these trials evaluated the effect of natural and synthetic progesterone administration during first trimester and commenced after pregnancy confirmation. These trials showed lower miscarriage rate and higher live birth rate was found in 8 trials that are used synthetic progesterone, that is dydrogesterone. So, in preventing recurrent pregnancy loss, dydrogesterone is more useful than natural progesterone according to these meta-analysis. There are so many global guidelines which favor use of progesterone in recurrent pregnancy loss. So, to summarize, endocrine and metabolic disorders, in overt hypothyroidism and in subclinical overt hypothyroidism, we should treat the thyroidism with levothyroxine to normalize the T3, T4 and TSH levels. In subclinical hypothyroidism, we should start supplementing thyroxine when the TSH level is more than 4 milliunits. In thyroid autoimmunity, where the thyroid antibodies are positive, that is TPY antibodies are positive, we should start supplementing levothyroxine when the TSH level is more than 2.5 milliunits. In cases with hyperprolactinemia, this hyperprolactinemia, according to guidelines advocated by either ISHRE or ASRM, the routine testing for hyperprolactinemia is not advocated. But those patients who have symptoms of hyperprolactinemia like algomenorrhea, amenorrhea, or galactorrhea should be investigated with prolactin levels, and if they have hyperprolactinemia, then these should be treated with a dopamine agonist like bromocriptine or cabergoline, which will reduce the miscarriage rate and prevent recurrent pregnancy loss. In polycystic ovarian syndrome, the metformin with PCOS can decrease the risk of recurrent pregnancy loss. And in diabetes mellitus, strict control of glycemic status is very important. Coming to male factor, in the various factors which can contribute to male factor are age of the partner. If it is more than 50 years, if the male partner is more than 50 years, the chances of aneuploidy will increase. Coming to semen factors, the most important factor is the DNA fragmentation index. If it is more than 24% DNA fragmentation index, there is increased risk for recurrent pregnancy loss. If this DFA is more than 30%, the chances of infertility are very high. Genetic factors of male, that is either microdeletions on Y chromosome or numerical or structural chromosomal abnormalities, can lead to recurrent pregnancy loss. For management of male factor, first and the foremost thing is lifestyle modification. We should advise them to achieve, optimize their BMI, that is basal body, their weight, and we should ask them to avoid environmental exposure to environmental toxins like alcohol and smoking. And we should ask them to decrease the ingestion of caffeine also. And healthy lifestyle should be advocated. And if this patient is having varicoses, the presence of varicoses will increase DNA fragmentation index, so the varicoses should be repaired. And antioxidants will play a role in decreasing the DNA fragmentation index, and these patients will be treated with antioxidants. And during, if there is successive failures after all these measures, we can do IVF ICSI for these patients with the sperm selection, with the selection of the better sperm using these either IMSI or PICSI procedures. And finally, we can select the best embryo by using pre-implantation genetic diagnosis. Coming to infections, no infectious agent has been proven to cause recurrent pregnancy loss. The infection can cause sporadic loss, but not recurrent pregnancy loss. Now, the bacterial vaginosis can cause second trimester loss or preterm delivery. So, coming to evaluation of these patients with recurrent pregnancy loss. As in any other disorder, the history is the mainstay. A thorough history should be evaluated, including complete obstetric history, where first we should know what are the era of miscarriage, what is the gestation when this miscarriage occur. Either it is the first trimester, then the etiology will be varied, or it is second trimester, and if it is a live born or it's a dead conceptus, again we will, if it is a live born, it may be because of congenital malformations. If it is a dead, it may be because of genetic etiology or maternal chronic illnesses. And we should also confirm how was the pregnancy confirmed, because in many patients they say it's a pregnancy loss. In fact, it is an irregular period. So we should evaluate whether it is pregnancy or irregular period by evaluating the history, whether it is confirmed with UPT or ultrasound. So ultrasound confirmation should be there to say it is a miscarriage. And any other complications associated, like any history of thrombotic episodes. And if it is second trimester loss, we should look for any evidence of any cervical incompetence. And we should take the history of exposure to any environmental toxins or drugs, and any surgical history, especially uterine instrumentation or cervical surgery, to rule out cervical incompetence, or any history of say malformed babies or mentally retarded babies, to rule out genetic etiologies. And we should take thorough history of any previous diagnosis, any previous investigations done and treatments done. And this thorough history taking should be followed by physical examination to rule out any, to find out for any features of PCO, SLE, or any other disorders that can cause recurrent pregnancy loss. Finally, to summarize the investigations that is included, depending upon the etiology, if we suspect genetic etiology, karyotyping of both partners should be done. If it is anatomical, if we suspect from the history, if we suspect anatomical factor, then we should do transvaginal ultrasound or 3D ultrasound if it is available. If we suspect endocrine factors, we should do either thyroid, TSH, TPY antibodies, HbA1c, and fasting blood sugar. Immunological factors are suspected, then we should do anticardiolipin antibodies, lupus anticoagulant, etc. So, to summarize the evaluation, we should start evaluating all these patients with recurrent pregnancy loss after second loss itself to improve the prognosis of these patients. And in some patients, earlier evaluation is indicated whenever the woman is older than 35 years, or if the couple had difficulty in conceiving, that is history of infertility, or if the fetal cardiac activity is identified followed by the loss, then earlier evaluation is indicated. The present consensus is start evaluating all patients with recurrent pregnancy loss only after 2 losses. So, to summarize, again, the first history and examination, followed by screening for any weight extremes and environmental factors. And all these patients with recurrent pregnancy loss should be evaluated for 4 factors. That is, one is endocrine factors. All these patients should undergo TSH, TPY antibodies, GTT, and HbA1c. And anatomical factors, a minimum transvaginal ultrasound. If there is a suspicion of cavity abnormalities, it should be supported with 3D ultrasound. And if there is suspicion of genetic factors, these patients should undergo karyotyping after 2 losses itself. The test, if any suspicion like if there is a history of thrombotic episodes, we can do hereditary thrombophilia. It is not included in routine screening. If this patient have any evidence of hyperprolactinemia, we do prolactin. If this male partner has any evidence of high DNA fragmentation index, like if there are varicocele, this patient is having extremes of weight or chronic illness or various habits like alcoholism or smoking, then this male patient should undergo DNA fragmentation index and should be treated. This test should not be done or torch panel, because the torch panel will never cause recurrent pregnancy loss or other immunological factors which will be detailed by my co-speaker, Dr. Suma. So, coming to management. The management is mainly first and the foremost aspect is supporting them emotionally, because loss of pregnancy can be a devastating traumatic experience to the patient, and it can lead to anxiety, stress, and depression. Instead of getting sympathy and support, usually they are made to feel that it is somehow their fault. So sensitivity is required in assessing and counseling these couples. An approach with sympathy and understanding is very essential, and we should never blame the patient as it is her fault. The management we can divide it into preconceptional and after conception. During preconceptional period, all these patients should be thoroughly counseled regarding that even after 3 consecutive miscarriages, the chance of having successful live birth is more than 70%. And the first management is lifestyle modification. The lifestyle modification itself can increase the fertility potential. It includes first, stop smoking, reduce alcohol intake and caffeine intake, and the BMI should be optimized. The underweight and overweight both are associated with recurrent pregnancy losses. And we should optimize the maternal endocrine and metabolic conditions. The diabetes mellitus, thyroid, and all maternal illnesses will be controlled properly. And we should control any infections like recurrent UTI, bacterial vaginosis, or any other infection, maternal infections should be controlled. And if there is any associated uterine abnormalities like septate uterus or any polyp or fibroid should be corrected, which can cause recurrent pregnancy loss should be corrected. And all these patients should be supplemented with prenatal vitamins like folic acid, vitamin D3, and multivitamins before they plan pregnancy. And any nutritional deficiencies like anemia or vitamin D deficiencies should be corrected because they are associated with adverse pregnancy outcomes. And some advocated giving empiric antibiotic to correct subclinical vaginitis and PIDs with chlamydia and listeria, etc., which can cause abortions. And luteal support. Some advocate luteal support after ovulation during this index pregnancy. Coming to management after conception. Tender loving care. Undoubtedly, this tender loving care will improve pregnancy outcome in these distressed patients. There's so many reports are available which show the efficiency of this tender loving care. The psychological support, positive psychological support in a dedicated clinic setting, complemented with weekly ultrasound and encouraging them and counseling them about the positive pregnancy result will improve the success rate in this recurrent pregnancy loss. And all these patients should be supplemented with folic acid and progesterone supplementation whenever it is needed. And the treatment should be based on etiology, like in case of Apla syndrome, this patient should be treated with low-dose aspirin and heparin. In case of hypothyroidism, we should supplement them with levothyroxine. And in case of cervical insufficiency, Cerclide should be applied in time. And coming to antenatal care, all these patients should have early and frequent visits. And first trimester aneuploidy screening should be educated and CVS if indicated, because These patients with recurrent pregnancy loss are more prone to have other pregnancy complications also. And TIFA and quadruple screening amniocentesis whenever it is indicated. And all these patients should have intense antenatal monitoring with DFMC and biophysical profile and NST every 2 weeks from the 32 weeks onwards. And steroid administration should be advocated for lung maturity because these patients are more prone to have premature deliveries and IUGR. And during delivery, intense intrabottom monitoring with the continuous topographic monitoring should be done. Coming to various treatment options for unexplained recurrent miscarriage, immunomodulation, which can be discussed in detail by other Madam Suma Prasad Madam. Supportive care, which we already discussed, that is tender loving care and supplementation with vitamins and progesterone, and role of progesterone, which we already discussed. Coming to role of aspirin and heparin, usually prescribed for women with unexplained recurrent miscarriages alone or in combination. The two recent randomized control trials showed neither treatment, either aspirin or heparin separately or in combination, improves live birth rate among those women which doesn't have APLA syndrome. Use of this empirical treatment is unnecessary and should be resisted. Coming to future pregnancy prognosis. There is a good prognosis for future pregnancy outcome. As we already discussed, there's 75% chance of eventual live birth rate in subsequent pregnancy. However, the prognosis will worse with increasing maternal age and increasing number of previous miscarriages. The maternal age and number of previous miscarriages are independent risk factors for further miscarriage. The greatest risk of recurrent loss occurs during the period of time of previous miscarriage. That means if a patient has a loss at around 10 to 12 weeks period of gestation, again she has a high risk of having miscarriage during that time. If she crosses that time, we can say she tied over that critical period and she crossed that they cross that what can we between the critical period. So presence of fetal cardiac activity is reassuring of subsequent viable delivery. All those patients who have second trimester pregnancy loss is associated with increased chances of recurrent second trimester loss and increased chances for spontaneous preterm birth also. The other obstetric complications associated with these patients with recurrent pregnancy loss are, as we already discussed, there's increased chances for IUGR, increased chances for premature delivery and perinatal death. So all these patients should have an intense antenatal and intranatal monitoring. Thank you.
Thank you, ma'am. Thank you very much for your detailed presentation, ma'am. Ma'am, without wasting time, we can go for the next speaker, ma'am. We can have the QA session at the end of this presentation, ma'am. We can have the QA session because the participants need time to post their queries. So we can go for the next speaker, ma'am. So I would like to welcome our second speaker for the today's session, Dr. Suma Prasad, ma'am. So madam is currently the director of Prasad Infertility Solution, Hyderabad. And madam is the gynecologist and IVF specialist with cell culture and cryopreservation experience since 2002. Madam has trained at UCL London for pre-implantation embryo biopsy. Madam has mentored by renowned cell biologist Dr. Lalji Singh and Dr. Gopal Pandey, CCMB. And Madam is the founder of Prasad Research Foundation, incubator facility for clinically relevant research and preclinical animal model design. Madam has established a first kind of its kind stem cell line for human placenta, SS1, and heading an oncology clinical study on endometrial regeneration in infertile women with placenta derived exosomes. With this introduction, I welcome you, ma'am. to give a lecture on immunological aspects of recurrent pregnancy loss. Welcome you, ma'am. Over to you, ma'am.
Thank you very much. Right? You got the screen? I hope you got the screen.
Yes, ma'am. It's visible now, ma'am.
Hi, Aruna. Thank you very much for that elaborate explanation. Wonderful slides. And thank you again for covering thyroid, the anti-TPO, diabetes, as well as prolactin and PCOD for me. So, friends, very warm good evening. And I thank Shield Pharma for giving me this opportunity. And I also thank Dr. Aruna for giving the complete explanation of recurrent pregnancy loss. And to my knowledge, I think the moment you diagnose a missed abortion, or she comes to you with bleeding and you suggest a DNC, there's a big chance that you lose the patient. So this always happens. So let me tell you honestly, friends, your skill lies in retaining this failed patient. Let's start the discussion with this. I'll be very brief. I want to discuss very briefly about the immunological factors, but I would like to leave you with a checklist and as well as the current guidelines, a small algorithm. Um, So I'll be covering just the medical condition and that to the autoimmune condition, which could have led to the recurrent spontaneous loss. Slide by Aruna, where she says 20% is autoimmune and 50% is unexplained, but many times we land up working up the immunological factors as well. This is one favorite slide of mine. As I said, you need to have a very clear understanding about normal implantation, what exactly happens at the interface, exactly at the interface. What's happening to the trophoblast? How is it managing to invade into the maternal endometrium, converting it into decidua, and entire maternal immune cell repertoire? They all sort of run towards this implanting a fetus, and then there is a big confusion whether it should be accepted or not accepted. Now here lies the smartness of the mother, honestly, and little bit from the innocent fetus, because it would still not know into which womb it is actually getting implanted. So the maternal immune reaction should be definitely be considered, and a lot of battery of investigations have been designed, and including the smallest of the cytokines are being investigated. But I think we should have a roadmap for our patient, for each individual patient. Design the roadmap for yourself. Whatever stage she comes, you have a clear roadmap from point to point, and you put your checklist in. And I think that's the best way to manage these women. Otherwise, as I said, there's a big risk of losing the patient. As Aruna rightly pointed, 70% of these women with recurrent miscarriages have a autocorrection happening in themselves, and they have a full-term pregnancy. So probably you just have to hold on to that patient, probably reassuring them, yeah, the best way is to socialize with your own patient. And that's the only way you can continue association with her and retain her. She'll definitely give you a full-term baby if you have excluded all the conditions which Aruna has clearly elucidated. In fact, mm, how exactly the fetus is adapted by mother itself is holds a lot of contradictory and very large contribution in the literature. Mothers and fetuses are always genetically different. 50% of the fetal genes and proteins are paternal. The developing fetus and the placenta express HLA molecules that differ from the mothers, and the mechanisms exist to inhibit rejection. Simple ones, the mechanical barrier, which was thought of for so many years, but I think now this particular uh, ice ceiling is breaking. The concept of mechanical barrier is not going to be worth thinking further on. I'm sure those who are very young now who joined the practice, in another 5 years, you will not even consider the mechanical barrier. You'll be talking only in terms of molecular barriers. The lack of HLA-2 antigen expression on the trophoblast. See, this is how the trophoblast actually makes itself very innocent, and the mother also tries to act innocent. They both adapt to each other. Mainly, it was explained by the lack of HLA-2 antigen expression. The other important HLA is HLA-G, which is actually a soluble factor. So there is no particular testing we have for HLA-G. It is an hypothesis, and of course, it seems to be proved pretty many times. Suppression of maternal immune response, as Aruna said, the Th1, Th2 balance keeps shifting, and there is a local immune suppression as the entire the maternal immune cell repertoire, the entire population tries to migrate towards this particular implanting site, especially the uterine natural killer cells. The suppression or the deviation of maternal immune response happens mainly through progesterone. So when Aruna said 400 mg progesterone twice daily, still it is not as good as the placebo, or probably doesn't give any better response. I think this is highly debatable. I'm sure Aruna will also finally agree that yes, we have to give progesterone, and even up to 1 gram per day is something explained in the textbooks as well as in conferences. We should give progesterone, and that's the only way we can actually understand that pregnancy can be continued. It's actually much understood phenomena. Progesterone secreted by the placenta is probably the most accepted phenomena. And as I said, the expansion of T cell, the Tregs, which are immunosuppressive in pregnancy. So there is a big debate again. If Tregs are immunosuppressive, then why is the mother not so prone for all sorts of infections when she's so immunocompromised? There's a nice explanation for that, which is emerging. I'll be sharing that with you guys. The Th1, Th2 switch, where there's a suppression of cell-mediated immunity, and affects the clinical course, of course, in those women where there is established autoimmune disorders. We do see women with SLE and rheumatoid arthritis, sometimes multiple sclerosis and myasthenia gravis. And in these women, yes, the entire immune system is already deranged. So pregnancy continuation in them definitely needs a special attention and a different team approach. Now, more understanding is based on the cytokines or the suppressive proteins, the Fas ligands, interleukin 10, transforming growth factor beta. Now, these are being more understood now. I'm sure, as I said, future is going to be more of molecular and proteomics. And I'm sure, friends, these are the some of the key proteins which will be eventually, they will become biomarkers for us. And as I said, in spite of being immunocompromised or immunosuppressed, how come this pregnant woman is still protected from a lot of infections? Of course, monilial vaginitis is what we commonly see. Sometimes asymptomatic bacterial vaginosis, asymptomatic. Some women will undergo early cervical incompetence, but there are many women who do a lot of asymptomatic bacteria, yet that infection is prevented, yet these women are protected. How does it happen? Now this happens now. Slowly the proof is coming out, and a lot of proof of concept articles are being now on the PubMed for your information, that placental exosomes, placenta along with the syncytial trophoblast, it actually keeps releasing small nucleated microRNA 499 plus a particular molecule called LIN28B. Now, eventually, these will be, as I said, these will be the biomarkers for us to understand if this pregnancy is going to be a successful one. Now, how is this maternal fetal interface being delicately balanced? There is a shift from pro-inflammatory to anti-inflammatory situation. The entire proteins as well as the other microRNA as well as the hormones, they all actually push the entire system towards an anti-inflammatory process, allowing the fetus to adapt itself. But once the pro-inflammatory markers are actually picking up, that is the condition where you see the recurrent pregnancy losses or IUGR, or probably the other related pregnancy complications. And in the immunological disorders, friends, as I said, I will be short because this is extremely dry and it just doesn't get into the head, it goes above the head. There are two types of thrombophilias broadly, the inherited thrombophilias and the acquired thrombophilias. In fact, with a woman who already has an inherited thrombophilia, a protein S deficiency, C deficiency, factor V Leiden, prothrombin mutation, or a MTHFR mutations, these women usually have coexisting morbidities. Either they would have presented with a rheumatoid arthritis or SLE or some other, probably PCOD or diabetes, whatever. They could have presented with some other comorbidity. So usually once a physician diagnoses inherited thrombophilia, I think we have to work in tandem with them and not start any quick anticoagulants by ourselves. Whereas when it comes to acquired thrombophilia, this is how the pregnant women actually present to us primarily. The antiphospholipid antibody syndrome is the most usually spoken of, but I'm sure you all agree that many times we get the APLA test done, and probably hardly 5 to 10%, maybe less than that, we see that the antibodies are positive. So it's actually not so common in women who would have had recurrent pregnancy loss. Why? There are a lot of specificities for this test. If it comes positive, you cannot say the patient that you have APLA syndrome. You are supposed to repeat the test after 6 weeks or 8 weeks or 12 weeks. There are different people advising different ones, but minimum 6 weeks or up to 12 weeks, you have to repeat the APLA test and then tell her that she is going through a APLA syndrome. And that's the time when we have to start the medication for her. The second metabolic abnormality which leads to acquired thrombophilias is hyperhomocysteinemias. This is what was taught by my mentor, Dr. Radharama Devi, who has done extensive studies on hyperhomocysteinemias. And she has actually very clearly presented published papers as to how hyperhomocysteinemia, which is a lifestyle problem, which eventually becomes a deadly hypercoagulable condition in men and women, leads to various reproductive failures. So eventually, whatever the thrombophilia, the woman is actually pushed towards a hypercoagulable state. Now, what is this hypercoagulable state? How does it happen? This is just a simple line diagram as to how the endothelial cell in the blood vessel, in the uterine arteries, in the spiral arteries, actually gets damaged because of the antibodies, and it starts expressing adhesion molecules. There is upregulation of tissue factors, which also is done by the mononuclear cells as well as platelets. They all start rushing towards this particular tiny blood vessels, especially in the uterine cavity. The moment the fetus is identified, the entire antibody production starts. This is an autoimmune disorder, we all very well know. So the antibody production starts when and how, we really don't know. But the secondary effects are the platelet activation and aggregation, as well as entire T cell immune response and pro-inflammatory kinins, leading to coagulation and thrombosis. Now, this is a nice way to explain to our patients why we are starting low-dose aspirin to them. This is a common question. Why did you start a low-dose aspirin? In our family, some old person who is suffering with a stroke or a cardiac ailment takes this low-dose aspirin. Why did you start? They might ask you just like that, but a lot depends on how you explain to them. You can draw a line diagram, or you can have a picture on your table explaining to them that platelet activation and aggregation is inhibited by this very small baby aspirin, and that can be of a big help. So no harm in giving these women low-dose aspirin. Along with that, when the question comes as to why you started low molecular weight heparin, now you have to have a very clear explanation for that, because they go and Google and they go and do all sorts of research. They take second opinions from somebody who is not so informed. So you have to explain to them that the only way to prevent coagulation in these small vessels which are giving oxygen to the baby is to by giving the low molecular weight heparin. I think this explanation should be very vividly given to them with pictures. Only then they're going to be compliant with whatever therapy you want to initiate. APLA, as it's said, it is seen in around 20% of women with recurrent miscarriages. But the importance here is that it is a treatable cause. The diagnosis of APS requires two components. One, she should have had a recurrent pregnancy loss, and second, she should have had the presence of antiphospholipid antibodies. Both lupus coagulant anticardiolipin antibodies are primarily important, and there are some people who advocate anti-beta 2 glycoprotein, but right now for us lupus anticoagulant and anticardiolipin antibodies are sufficient. Now, the values matter a lot, which I'll discuss later. The antiphospholipid antibodies are thought to impair pregnancy through various mechanisms, including inhibition of trophoblast function, thrombosis of the uteroplacental vasculature, placental ischemia, and initiation of a local inflammatory response at the maternal fetal interface. Diagnosis of APS requires moderate to high titers of ACL or high titers of lupus anticoagulants, at least more than 20 international units on two separate occasions, at least 12 weeks apart. Now, this is as per the RCOG guidelines. So I think we should be strictly adhering to this before we start medication or counsel the patient for that. The treatment is earlier, it was a lot of studies, they started with unfractionated heparin, and the moment there is a positive pregnancy test, ideally it should be a intrauterine sac. And then along with that, you can add a low dose aspirin up to 34 weeks of pregnancy. Low molecular weight heparin is now very popular and has the benefits of once a day administration and a superior safety profile for thrombocytopenia and osteopenia compared to heparin. Of course, we don't give heparin anymore. There is one good study, a randomized study of 60 women, found that low molecular weight heparin was not inferior to heparin in women with recurrent miscarriages. But of course, we need large prospective trials. In fact, I was requesting Shield Pharma to share a template for a clinical study, which is good for all of us. We can have a local study. We have very good, very strong gynec societies. So probably a multi-center study, clinical study for those women with recurrent abortions, for those who have started low molecular weight heparin, a simple clinical template, if we can make it and probably conduct a study, it will be very worth it. And there is a lot of interest in inherited thrombophilias because they might not be very classical representation of the antiphospholipid antibodies or the symptoms or signs in them. Because if they would have had, as I said, pre-existing SLE or rheumatoid arthritis and some other autoimmune disorders, the entire clinical picture actually changes during pregnancy. So it's very important that you work in tandem with your immunologist or your general physician. Otherwise, it's very difficult to counsel these patients or try to identify problems early and prevent recurrences. There is a lot of association between inherited thrombophilia and recurrent fetal loss. Nothing much has been confirmed. Of course, there are meta-analysis of 8 trials involving more than 400 patients with previous history of recurrent losses and found no benefit with low molecular weight heparin. A Cochrane review of 9 studies involving more than 1,000 women with a history of 2 unexplained miscarriages with or without thrombophilia also found no improvement with aspirin or low molecular weight heparin or a combination of both. But Friends, let me tell you, there is an ongoing A-Life 2 anticoagulants for living fetuses 2 study. This randomized controlled trial will definitely and hopefully clarify guidance on using the low molecular weight heparin in women with inherited thrombophilias. Now, here comes the checklist. I prepared a small checklist for you guys because I thought it's important that we make our own checklist for that particular patient and stick it to her case sheet and have one in our diary. It's also because these are important patients. Aruna has covered most of the investigations because these are what we have to we are supposed to search in her previous records, and a fresh complete blood picture is important, and HB electrophoresis to rule out THAL is even more important. A single test is sufficient. Lupus anticoagulant and anti-cardiolipin antibody titers. Here you have mild, moderate, and severe. The treatment depends a lot on these mild, moderate, or severe. If it is mild and moderate, the treatment can be low dose heparin and low dose aspirin. Okay, low molecular weight heparin and low dose aspirin if it is mild and moderate, that is 0 to 5, 5 to 20. Now, if the lupus anticoagulant or is anticardiolipin antibodies are more than 20, that means definitely there is a high antibody titer in this woman and she needs a steroid. As I said, this has to be a team approach, and giving a steroid has to be thoughtful and probably a short term therapy. Long term therapy, I'll discuss with you the side effects. Homocysteine levels, as I said, the fasting homocysteine levels are important and they do reflect the underlying metabolic condition leading to either sperm DNA fragmentation or probably a very poor oocyte quality or probably a very poor embryo. TSH, anti-TPO and prolactin are very nicely covered by Aruna. We still believe that women who are euthyroid still have to undergo anti-TPO. And a word about prolactin. If this woman has been treated with clomiphene citrate, friends, please understand, don't get carried away with prolactin levels in one go. Please be careful about underlining the prolactin report. If they are on selective estrogen receptor modulators, which should have acted on anti-pituitary, definitely the prolactin values also increase. This ACTH also increases, TSH also increases. So there is a lot of variabilities in these women who are taking clomiphene citrate especially. So before you actually think seriously about these hormones, you just check the previous history of clomiphene citrate intake. Clomiphene citrate sometimes stays in blood for more than 35 days. So there's a big chance up to 2 months that the hormone levels may not come back to normal. Hemoglobin A1C is covered by Aruna very well. Bacterial vaginosis, one of the most important issues. So, of course, it doesn't come in the perspective of the immunological issues, but there are reasons now very clearly pointing out how the autoimmunity starts. It could be due to an infection, a low grade underlying infection of viral or bacterial origin can induce antibodies in these women. Anti-nuclear antibodies, as I said, as Aruna said, is not very important. That's why I put it in red. And if somebody has already done the test, don't comment about it. Leave the report there. Previously diagnosed autoimmune disease, if the woman has. Now, we better not become Columbus and start reinventing her antibodies. We better work in tandem with the physician who is actually treating the patient and then check the issues relevant to pregnancy management only. Now, the checklist for therapy, I think this is also important. You need to have this checklist because she would have received at least 2 or 3 of this among the checklist. Let's start with progesterone. I think the most wanted and probably most opted for and the safest and no harm. So progesterone, by all means, you think about the dosage, whatever is required for her, and up to 1 gram is what is advocated by many reproductive endocrinology and infertility specialists because it is supposed to immunomodulate so efficiently. Low dose aspirin, despite all the criticism, despite all the contradiction, it still has its value in these women right from post ovulation, right from post ovulation up to conception, and you can continue if she doesn't have a bleed. So low dose aspirin still holds very good because it has a very strong physiological basis as to how it works. Low molecular weight heparin, if the woman has already used and she didn't have a side effect, I think you can recommend it during the present pregnancy as well. Lymphocyte immunotherapy is something which is very interesting. In fact, this is how my journey in infertility started way back in 1994, where Dr. Pranay Shah in Bombay, when I attended his lecture, he was very actively advocating paternal lymphocyte infusion to mother in the subcutaneous, as subcutaneous injection. And then a lot of questioning to him, and he was very clear how this lymphocyte immunotherapy actually helps the woman to bring down her immunity towards paternal antigens. And I was surprised to see a latest article about lymphocyte immunotherapy. This is, of course, a lot of theoretical importance is there, and you guys can read about it. Coming to steroid therapy, prednisolone, if there are high levels of this anti-lupus anticoagulant or anti-cardiolipin antibodies, prednisolone is indicated, uh, but a short-term prednisolone therapy is what the physician suggests, because the long-term prednisolone therapy is actually not so good. Maybe we might get tempted to give a long-term steroid therapy for women who have had recurrent abortions 4 times or 5 times, because we've got to treat her somewhere or the other. We've got to keep her immunity low. But long-term prednisolone does reflect a chronic stress-like process in the fetus, a chronic stress-like phenomena, which is just like the Barker's hypothesis, where the mother is malnourished and the fetus goes into stress. So prednisolone on long-term administration can have detrimental effects on the fetus. It can induce fetal onset of adult diseases. But as a short-term therapy, yes, it has a role, and I think we'll have to individualize the case and plan for the steroid therapy. IV immunoglobulin has no role. In fact, it never gained popularity. GCSF, granulocyte colony stimulating factor, for everything they started giving GCSF, so it became very unpopular. I don't think we advocate GCSF now. Mm. Intralipid is occasionally we see prescriptions of intralipid. Let us not comment about it, but yes, it is. There are some proven papers, but I don't think intralipid actually helps in continuing aborting pregnancy, or even prevention. In that case, it's highly debated. TNF alpha inhibitors in US, there's a big hype about these monoclonal antibodies, and they have proved TNF alpha inhibitors, adalimumab, as the Humira, as effective therapy in some of the recurrent miscarriages. But I don't think we'll be able to use that. But now I'm sure all of you experience a flow of patients from US coming to India, so they will definitely have all this in their checklist. So we should be able to answer that these particular monoclonal antibodies are not popular in India and we don't advocate them. Well, let's come to HCG, our favorite injection. Uh, Again, I think it should not be debated much, because there is good enough evidence as to how HCG does help a woman to switch her immunity towards a anti-inflammatory process. So I have a nice slide. It's a screenshot taken from this nice article. Uh, Here, I was actually happy that these people are now going back and explaining how estrogen, progesterone, and HCG, they modulate the inflammatory pathways. You can take a screenshot of it, but I simply fell in love with this slide, because every time we start estrogen for a woman with thin endometrium, I think we need to definitely have an answer now, that we can explain that it brings down the pro-inflammatory pathway and actually stimulates the anti-inflammatory pathway. And added to that, progesterone and HCG can accentuate the anti-inflammatory response, and eventually the effects of on immune cells are definitely observed, as HCG attracts the Tregs and induces uterine natural killer cell proliferation through some particular receptor, and it also it promotes the other immune cells to move to the implanting site. New algorithm for evaluation of RPL. Among all the investigations that Aruna has explained, I just marked out those in the red box for you guys. The antiphospholipid antibodies, um, Royal College advocates, ASRM advocates, says yes, you should do it. And of course, now it is proposed that you do lupus anticoagulant and antiphosphatidylserine serine antibodies. Right now, I think we have two, lupus as well as AC anticardiolipin antibodies. These two are sufficient for us. Hereditary thrombophilias, as I said, it's still controversial. Only after the discussion with the physician, you can go ahead with this detailed investigations of protein S, protein C deficiency, and the rest of the ones. Just a small take-home message. As I said, retain your failed patient. Never give up on her. Every human fetus, you have to keep explaining to the patient that it has its own antigens, and it is definitely a foreign body, but mother's womb takes it. And the various mechanisms are, of course, very clearly, lucidly explained. The immunological causes are about 20 to 50%. But most of the times we don't find a specific investigation pointing towards an immunological problem in these women. So giving, it is not an empirical therapy, it is definitely therapeutic to advise low dose aspirin, low molecular weight heparin, occasionally a steroid therapy in women after 2 or 3 consecutive miscarriages. Thank you, guys.
Thank you very much for your detailed presentation, ma'am. And ma'am, if you allow, then I can read the questions in the chat box, ma'am.
Sure.
Yeah, there is one question from Dr. Sudhamani, like whether hypothyroidism causes difficulty in conceiving or recurrent pregnancy loss.
Aruna.
Question is for Arna, ma'am.
So it's a spectrum of abnormalities. The hypothyroidism can cause both infertility and recurrent pregnancy loss. They're not entirely different disorders. It's a spectrum of one event. If this hypothyroidism is really more overt hypothyroidism, uncontrolled hypothyroidism can lead to infertility.
Yeah, ma'am. And the next question is whether large fibroid in the uterus, how to treat to conceive as well as to prevent pregnancy loss.
So myomectomy, if this large fibroid is subserous fibroid, which is not causing any, which is not interfering with the conception or endometrial cavity, no need for it to remove. If it is large fibroid, either intramural or submucous, which is causing distortion of the cavity and which is interfering with the implantation, then we should do myomectomy. Either it can be laparoscopic or laparotomy depending on the size of the fibroid. If you are efficient and well versed with the laparoscopic myomectomy, up to 5 to 6 centimeters, you can do laparoscopic myomectomy. If it is submucous fibroid, more than 3/4 is in the cavity, you can go with hysteroscopic myomectomy.
Okay, ma'am. I think Dr. Sudhamani ma'am has received an answer for a query. And there is another query from Dr. Saunitya Banu, like, is metformin indicated in pregnancy, ma'am? It leads on to childhood obesity at 7 years of age.
So now the GDM is on rise. So there are many papers which show the metformin is safe during pregnancy. But as I already mentioned, the long-term effects of this metformin on the siblings is not well established. The data is very less. So whenever needed, we can give metformin, but the drug of choice is insulin. Till at present, the drug of choice is insulin, but there are some information that metformin is also safe during pregnancy.
And I think you can definitely check the maternal habitus, because most of the women who are have other comorbidities, obesity or type 2 diabetes, which is not well controlled, their children definitely, I'm sure everything at home is also not so good. You tend to see obesity in their kith and kin.
Okay, ma'am. The next question is from Dr. Samthya Bon only. Why metformin should be avoided between 12 to 20 weeks, especially, ma'am?
Mm.
So there are no studies which showed that we should avoid this between 12 to 20 weeks. All the papers which I have gone through, they said we can use throughout pregnancy. Madam, do you have any information, Madam Suma, Madam?
Yeah, when you can use it during the organogenesis period, I don't think there should be any restriction to use it up to 20 weeks, number one. Number two, I think metformin alone may not be sufficient for that woman. You have to check a lot of other parameters also, whether she's controlled or not controlled.
Okay, ma'am. Ma'am, and what should be the dose of low molecular weight heparin, ma'am?
Mm.
What is the dose of heparin in proven APLA cases?
Yeah. It depends on the maternal body weight as well. It can be single day administration, right from 40 milligrams up to 80 milligrams.
When it should be stopped in APLA positive case, ma'am? When that is heparin should be stopped in APLA positive cases?
We actually don't stop it till term, and up to 34, 36 weeks we had to continue, and probably just before the planned delivery we can stop it. But as soon as she delivers, again by 12th hour, the anesthetist or the obstetric anesthetist will definitely advise another dose of low molecular weight heparin, as well as prevention of the other thromboembolic phenomena in them, like putting up the stockings or ambulating them early. Mm.
It's not necessary to do beta to glycoprotein evaluation in our contest.
No, no, it is very well explained, but I think the kit is not freely available. The kit is not available in across most of the diagnostics. When we ask for the APLA package, they usually offer lupus anticoagulant and ACL, and these two values should be fair enough unless until we have more doubts. I mean, being practical. Is that fine, dear?
Participants, you can directly unmute and you can have the question with the presenters directly.
Isn't it their OP time? Cost of thrombophilia profile, I think you can check with your local diagnostics. Everybody has some similar profile. Thank you. Karyotype, I think Shweta, karyotype, I think Aruna has covered, and she's covered very clearly. You just go back to her slides and check the indications and the contra and why it is not advocated in some. Aruna ma'am,
No.
karyotype.
What is the exact question?
She says karyotype question, 2 question marks.
Karyotype. What is Karyotype. So exactly, I didn't understand the question. What is it role of karyotype in recurrent pregnancy loss?
Shweta, unmute yourself.
When should be advised? Okay. That means whenever there is an indication or suspicion of genetic etiology, like recurrent early first trimester losses or advanced maternal age, or in the indication of previous baby with malformation or family history of congenital malformations, or evaluation of products of conception, genetic analysis of products of conception showed unbalanced translocation, then these parents, this commissioning couple should undergo, both wife and husband should undergo conventional karyotype. Is it okay?
Yeah, we can have probably a detailed discussion of whether karyotyping or microarray or whole exome sequencing in the next session, probably.
There is a question from Dr. Usha. Any like significance of
APT is elevated in Dr. Usha's patient, more than 48. So in the case of previous stillbirth or neonatal death, APT is okay. APTT is associated with prothrombin mutation. So when you have raised APTT, please understand it is, again, you have to repeat the sample, and if it is still continuing to be elevated after 6 weeks, then I think you'll have to definitely investigate or probably talk to your hematologist or the physician to look in for inherited thrombophilias. Shweta, pregnancy alone, you got to be careful. And as I said, it depends on the situation. It has to be individualized. We can start with 5 mg TID or sometimes 10 mg TID, taper it and close it within a month. Yeah. Puberty, menorrhagia, these are the dangerous girls. They are the ones who have underlying thrombophilias. They are the ones underlying various complement deficiencies or dysfunction, or even coagulation factor deficiencies. So they start expressing their coagulation, this bleeding diathesis when they attain menarche. That's the only time when they actually start having bleeding from a raw area. So when they come with raised APTT, you have to follow her up. You have to have a discussion with a hematologist. Don't just leave them alone. Put them on OCP. That will cover a lot of future problems for you. Fine. Thank you. Thank you, Aruna. And
Thank you, ma'am. Thank you so much.
And thank you, Dr. Someshwar and Yakaya, for those nice
Thank you.
slides.
Thank you, ma'am. Thank you. Thank you, Suma, ma'am. Thank you, Aruna, ma'am. Special thank to Suma Prasad, ma'am. Especially once again, ma'am has come as an esteemed speaker for our program. And Dr. Aruna, ma'am, once again, thank you. Thanks a lot for an interactive and a very useful session for all, ma'am. Thank you once again. Thank you.
Thank you, Suma madam, and she'll be
I think
all
Dr.
participant
Sarojini,
doctors. Thank you so
Madam
much.
Sarojini Devi is also saying something.
Good evening, ma'am.